So Prof. Rick asked that I discuss some of the problems that we've had with continuing our research protocols in the prison system during the pandemic. So we'll talk briefly about our experience. Disclosures, no conflicts of interest. So before we get into what's happening during the pandemic, I just want to step back and talk about, and kind of set the stage, and talk about just the challenges of prison-based research even before the pandemic. And I think many of you who might have worked in the prison system are aware of these challenges, but for those that are not, I just wanted to review. So just as a reminder, in the prison system, prisoners are not free to participate in studies and attend study visits and at their will. Everything is highly dependent on cooperation from the prison administration. We depend on the facility staff for everything, making sure that the patients are screened, are brought to the screening area, or have time to sit down with the research staff, are able to have privacy or not, as the case may be, in reality, with our research staff in a separate room, as Prof. Adiba mentioned earlier. So everything has to be very much in concert with the prison operations. And those of you who have worked in the prison system know the prison system is very hierarchical. You need the approval of the prison leadership, prisons department, for everything. And so it can be quite challenging to move forward, to make changes, to try to streamline processes. For those who don't know, any protocol, any research study that's approved or for funding through NIH has to, beyond just IRB approval, has to get approved on a separate level by a special NIH office to ensure that proper protections are given to the prisoners. It's an extra level of protections that are afforded to protect this vulnerable population. And though it may seem like an obstacle or a delay in our timeline to get the study moving, there's a good reason for that, right? We know, just like we talked about this morning, that the rights of prisoners are constantly being violated, and so having those protections in place is just one level of assurance that we're doing the right thing. Confidentiality is critical, obviously, to any sort of research process, making sure that we can talk to our participants and reassure them that what they're telling us is not being monitored, that we can get the direct, straight opinions that they're offering, what they're telling us is true. But in the prison system is very challenging to achieve. We don't always have that confidential, private area to talk with our participants. People may not trust that we're independent from the prison administration. They may fear that the data that we're collecting is being shared and may be used against them. And that takes time, right? We have to build that rapport and that trust with our participants. And as we've alluded to already, but just to reiterate, physical distancing is not possible. The overcrowded conditions, the sharing of cells, the common facilities like dining rooms, bathrooms, all of that make all sorts of services very difficult to provide. As a reminder, in prisons we have a high concentration and coalescence of substance use disorders, HIV, other comorbidities like we talked about, tuberculosis, hepatitis C, etc. And as it pertains to COVID, there's certainly been massive outbreaks that have been reported in numerous settings. Prisons and jails, while we think of them as contained settings, actually are quite porous. People are going in and out all the time. New prisoners are coming in, prisoners who've been inside for some time are leaving, but just even on a day-to-day basis, the staff, and that includes the medical personnel, are coming in and out multiple times a day. And just as an aside, there's colleagues in other global regions who have documented increased TB, for example, in the areas, in the communities immediately surrounding the prison, just as evidence of that. So what happens in the prison is not just happening in the prison. And then just as a last reminder, as we've highlighted this morning, prisoners are very much low priority for any sort of care, treatment, prevention, and that, as it pertains to COVID, that includes PPE, testing, vaccination, all of those. Okay. So in terms of functioning, research studies are functioning during the pandemic. Certainly there have been lots of barriers, a few facilitators, but lots of barriers. Accessing our participants, given all the restrictions, evolving guidelines from the ethics committees on how we should be proceeding with our research protocols, what restrictions should be in place, mitigating risk for our research teams. Right? In the early days of COVID, we didn't know a lot. We were still trying to figure out what the appropriate protection levels should be. What was the appropriate distance to maintain? There was controversy about that. There's still controversy about masks, but we have more science behind that now, right? So there was a lot of uncertainty in the early days, and things have improved and streamlined over time. But this remains a concern, is protecting the research staff and protecting the participants. And lastly, a lot of challenges in terms of operating within the institution and across institutions. So, in terms of facilitators, there have been some positives that have come out of this time. We've become a lot more adept at working online and finding solutions to working through our protocols using Zoom, using telehealth, using all sorts of remote methods. A lot of different types of collaborations and cooperations amongst different stakeholders in the research realm, and finding revisions to performing informed consent, right? Which previously was considered very rigid, and we've had to learn how to work with that in this setting of the COVID pandemic. Specific to the prisons, also, I think what some of the challenges that we've experienced, as opposed to our routine procedures pre-COVID of being in the prisons on a daily basis, talking with our colleagues in the prison administration, talking with the guards, maintaining those relationships that ultimately facilitate the study being done, right? We were no longer able to do that. And so those relationships, which are key to any project, as well as any research protocol, we weren't able to maintain those. And so that definitely was a deficit that affected protocols. Even the research teams took some time to readjust in terms of how we were communicating with each other. How often, are we in the WhatsApp group that we're going to check in daily, weekly. We're going to get into this a little bit more, but some of the protections, seemingly, for the participants in terms of new policies on how to rule out COVID upon prison entry, that really had an impact on our protocol in particular. And again, protecting the research staff. Relying on non-clinical personnel within the prison administration to get a lot of stuff done because our teams just couldn't get in. Right, and that includes collecting specimens, getting people to tests, having them meet the chest X-ray team. That's the portable chest X-ray team to come in and do screening. Chest X-rays on our people who are being screened for tuberculosis. All of these were very big challenges. Just briefly summarize what we discussed this morning. The Harapan 2 studies, basically screening every person with OUD entering the prison for tuberculosis through symptom screening, through a variety of laboratory tests, x-rays, etc. And then developing the best practice for screening within this population. those who are testing positive for tuberculosis were linking to treatment and trying to make sure that's happening in a timely fashion. Those who were screening positive for latent TB were offering them enrollment to the trial comparing 2 different TB regimens, looking at treatment completion and tolerability. And then lastly, in the blue on the bottom right, for those people who are with active or latent TB, we're offering a preference trial for buprenorphine versus methadone. So everyone coming in with the new COVID policies had to undergo COVID screening. And that involved a 2-week quarantine and then regular testing with PCR. And just to show you what that looks like, and this slide is courtesy of Asst. Thank you for the slide. Anybody who's coming in underwent a 2-week quarantine, 10 to 20 individuals in a single room while they're being ruled out for COVID undergoing testing. And that takes several days for the test to come back. If they're negative, after the 2 weeks, then they go to the next step in the prison orientation. If they're positive, they get transferred to another room with all the other people who are positive for COVID for another 10 days. And then at the end of the 10 days, they all have to check. They have to get tested again until they're test negative. But they're all in the same room together. So you can envision what that looks like, an ongoing transmission to each other. And we all know that, or hopefully we all know that, people can stay positive on an ongoing basis, but that doesn't necessarily mean they're transmissible. So some of these policies were not necessarily based on current science. And so people had to cycle through here until they were negative. And so sometimes that meant that they're in this cycling for weeks. And then they go through the prison orientation process, which takes another week. And then we're able to do their screening for study for TB symptoms. And so if you can imagine, one, there's a tremendous delay by the time that we're able to see them, sometimes up to 2 months or more. And if someone's coming in with tuberculosis, active tuberculosis, they've just now gone through 2 months in the prison and potentially have spread it even further. And some of the symptoms of tuberculosis overlap with the symptoms of COVID, which makes it all the more complicated and confusing. People with injection-drainees, which makes up 60% of the entrance to prison, as Prophet mentioned, are at significantly higher risk for severe COVID disease and severe COVID outcomes. Transmission is just ongoing without the ability to isolate or quarantine at an individual level. As I mentioned, weeks and months are lost in the screening process and then getting people diagnosed and into treatment. So ultimately, this comes down to another potential human justice or social justice, human rights, social justice issue. That delay in care. Secondarily, our goal is to get people diagnosed on prison entry, get an accurate estimate of prevalence on admission. If we're not testing them until 2 months later or more, that's not an accurate representation of prison entry. So maybe they got the TB while they were sitting in that closed COVID room. So, in any case, so in our case in Kajang prison, the prison was closed temporarily up until mid-2020. The staff couldn't even enter or enroll participants. And again, we had to rely on the prison staff to dispense medications for the people who were already enrolled. Once the prison was opened, it was again on a restricted basis. We were only able to go in once or twice a week with limited staff, with the ongoing staffing shortages, so we were only able to have our movement within the prison was restricted because there were fewer available escorts. Again, the delays in offering COVID vaccination, again, implementing the protections. Poor communication between the patients and the prison staff. While the prison staff were responsible for dispensing medications, we weren't always sure if that actually happened because of poor documentation and communication with our teams. Also, because of the restrictions of the prison, we weren't able to bring in the chest x-ray services, so again, that further delayed diagnosis. So overall, we experienced a tremendous amount of delays in conducting the protocol activities, enrollment, follow-up visits, but more importantly, perhaps than just the protocol, is that we were delayed in identifying people with active TB and getting them started on treatment. We were delayed in identifying people with latent TB and getting them started on treatment. And there was also delays in getting people with HIV initiated and maintained on antiretroviral therapy. So they may have previously started, but they had treatment interruptions, even for not getting their chronic medications, which, as we know, has a lot of implications for development of resistance and overall outcomes. So we're still recovering from all of that and getting our teams back on track, getting our enrollment back up, making sure that we can account for all the outcomes during that time. And it's difficult to estimate. I'm hopeful that we'll be able to have some insights as time goes on about what the impact was of that delayed diagnosis. So hopefully I can report more on that next time. Just taking another step, what we're doing in Ukraine. So we are working with Profric in Ukraine to improve outcomes from tuberculosis there as well, and looking to integrate TB treatment with antiretroviral therapy with OUD treatment. Our first foray there to the prison system in terms of tuberculosis is to conduct a multi-level assessment guided by the Asst framework, which we've all heard a lot about in the last couple of days, and looking at the in or out of context, interviewing all of the stakeholders. But obviously COVID interrupted this as well. So again, because of COVID restrictions, we had delays entering the prison, we had delays in setting up our workflows, and we had to alter our workflows actually. So now we're conducting interviews remotely, and we've had to change our original plans to number group technique, as Profric went through yesterday what number group technique was, and are switching now to individual interviews because of the COVID restriction. We can't have multiple people in one place, unfortunately. So some of the gains, some of the methodology, unfortunately, has had to be revised. But I'm hopeful that we'll still get rich information through individual interviews. So, just learning from all this, certainly no one could have foreseen the impact that the pandemic would have had just on our daily lives, but also on our research protocols. And we've had to learn as we've gone through all of this in the last 2 years. We've had to adjust, revise, and constantly reevaluate what we've been doing to make sure that we're doing it the safest way possible for our staff, for our participants, and for the rigor of the study. Going forward, though, I think we need to be better about anticipating and planning and preparing, not only for the next COVID surge, which is undoubtedly coming, right, but also for the next pandemic. I think we've learned, even if it's not next year, maybe 5 years down the line, maybe 10 years down the line, I think we've learned that these are not unique events over time. And so making sure that we have protocols and SOPs on how to work in different capacities and still preserve the protocols that we're and goals that we're trying to achieve, make sure patients are able and participants are able to continue receiving services, and develop better protocols for collecting data when we're not able to be in person. So I'll leave it there. I know everyone has a lot of experience at this point and look forward to discussing further.